And welcome to this special episode of The Dental Guys. I'm Wes, the Dental Guys.
And I'm John, the dental guy. And man, I'll tell you, Wes, the hits just keep on coming here. This last couple of weeks, we've had some really great discussions with some really awesome people, and this has been, I think, one of the times I feel like I've learned a lot. I feel like it gets me kind of ready to go back and with some new ideas. And we've been kind of kicking around this topic we're about to introduce for a while, because I think occlusion is one of the most confusing things to most clinicians. It certainly was to us before we kind of dove in out at Spear on this. And there were really some of the first times I really felt like I truly understood where I needed to go. And so we've got a special guest with us today. Wes, you want to kind of introduce Darin a little bit, bring him in on the conversation?
Darin is probably I'm just going to pump him up a little bit here. He has been on our podcast more than any Spear faculty, and it's because we have a special connection, and it started really from the very first time we met, and it was coffee, right? It was coffee, right? And every time we try to get out there, we try to go get a bag of coffee for Darin. Now, I might be setting myself up. I've got coffee for other Spear faculty members here. And even some of the people behind the scene, I've hooked them up with some coffee, and John, you have too. So I want to bring Darin on. And Darin, have you been drinking enough coffee lately? Because from what I understand, it's a ghost town at Spear Education right now from a standpoint of faculty. And how's the coffee? How's the campus doing?
Yeah, well, I'm on the campus right now, and there aren't very many other people here, so there's no line at the coffee machine. It's in some ways kind of nice, kind of beneficial. Yeah. I'm getting plenty of coffee in case you guys are worried. My caffeine intake is substantial.
Yeah, we've been drinking maybe a little bit more.
Be hurting.
Yeah. So, Darin, all jokes aside, though, we appreciate all the workshops that Darin has been involved in teaching to us, which we've been involved in. Many of those workshops have been just next level. And if you haven't had an opportunity to take some of the seminars and workshops from Darin, we're going to talk a little bit about that at the end of the show and what he's actually doing right now. But the main reason that we brought Darin onto the show today is to talk about occlusal design, and this idea that there's a lot of confusion when it comes to what kind of occlusion do I design for a removable prosthetic, full over full, and what type of occlusal design do I design for a fixed prosthetic, full over full, and then how that all works out in between, because we have a myriad of choices that kind of meet up in the middle. And dentures, Darin, John and I've talked on the show for years, is that we love dentures because, and what we like about dentures is that it helps us treatment plan where 8 and 9 need to go. And if you look at the Spear way of treatment planning, it starts with, well, of course, Airway, right? But then it starts with aesthetics right after that, and that's the position of 8 and 9, and that's basic dentures. Darin, talk a little bit about this whole idea of occlusion and where we're at with some of the basic concepts.
Yeah, so one of the nice things about learning a conventional denture technique is you're really starting to kind of build a foundation for aesthetics, right? You're both functionally and aesthetically kind of figuring out where you want the teeth to be, but it's going to begin with aesthetics. And that's one of the reasons why, even in dental school education, why conventional denture treatment options are so valuable. Dental schools now are having trouble finding patients, finding enough patients to allow students to kind of have the experience level that they might otherwise want to have to learn really solid kind of denture techniques. But one of the things that is really valuable, I would say, when you're able to actually work with an edentulous patient and you're going to restore them treat them with conventional dentures is you get to see how the patient can struggle and how they can kind of begin to overcome that struggle as they're learning how to function with a conventional removable prosthetic or even full over full, right? And so you think about, well, I need to set up the occlusion, set up a functional sort of a design with something like conventional removable over conventional removable. And so let's start there. And we can actually back up just a sec and say, well, what was lost when the patient lost their teeth, right? We're going to restore them with conventional dentures. But when the patient lost their teeth, I mean, they lost a ton of stuff. So they lost the aesthetics. They lost a lot of kind of the ability to chew without thinking about it. They lost, in some cases, the ability to speak clearly without, having to think about it. And when the teeth are lost, along with all the psychological sort of damage that occurs there, they're also losing the PDL. They're losing the mechanoperceptors that are telling the brain, feeding information to the cortex about where the teeth are in relationship to one another, how hard the person is biting. Are the teeth touching, perfectly where they're in their MIP? Are they off a little bit? The patients who, once they lose their teeth, all that real kind of fine discrimination goes away. So compare that to someone with natural teeth. I mean, we're all at home now, and imagine you're sitting at home and you're watching TV or something, and you get a hair in your mouth. You can feel that, and a hair, something on the order of like 8 microns, you can discriminate that between your teeth. Once the teeth are gone, that level of discrimination goes away. The other thing that goes away is the support for the teeth. So the denture teeth, as we're setting the maxillary teeth in a way that's going to give us kind of optimized appearance. So we're trying to support the cheeks, the buccal corridor. We're trying to kind of get everything dialed in so that we're creating a believable tooth position, an aesthetic tooth position relative to the rest of the face. The support for that denture is typically not directly underneath the maxillary teeth. And this can create some real problems for denture patients, right? As they start to do that thing that every denture patient wants to do. They want to bite in an ear of corn or bite into an apple. The area of support is no longer directly underneath the teeth. And so as the patient incisors or bites on their anterior teeth, that's going to create a destabilization event for the denture. And you can wind up having some retentive problems as well. But the denture for sure is going to move. So patients are losing actually quite a bit of the stuff that they need to chew easily and efficiently. And so if you look at like concepts around designing denture occlusions for conventional denture patients, our concepts evolved as a way of trying to minimize the prosthetic movement that we have with conventional dentures. So we start thinking about things like a fully balanced denture occlusion, right? Where you've got the teeth touching on the working side, the non-working side, and then so that's cross arch balance. And then you've also got cross tooth balance that fits into that. So you're trying to maximize the tooth contacts as the person is coming into or away from their MIP on the dentures. But we're doing that on the posterior teeth, trying to help the stability of the denture through the occlusion. Does that make sense?
Yeah,
now,
totally.
Now, one of the problems that denture patients have is in addition to not being able to kind of feel that the teeth are touching, they're also not able to generate as much force as a dentate patient could.
Yeah, speak to that a little bit. I think it's like a decrease in almost down to what, 30%?
It's like 18% or something like that, or real low.
Yeah.
Yeah, it's low. So patient with natural teeth, right? If you measure at the molars, something on the order of 200 newtons And this varies from study to study, and it varies which tooth you're looking at. And there's some other factors that can sort of roll into that. But let's agree that on average, right, a normal dentate patient, well, maybe not normal, but a dentate patient could generate something on the order of 200 newtons if you measure it at the molars. If you take a dentate patient who's a bruxer, right? A bruxer can generate something on the order of 800 or 900 newtons measured again at the molars, so significantly more. But to put that into perspective, our conventional denture patient, like on the best day, you might be able to get them up to 60 or 80 newtons. Like way, way diminished in terms of the occlusal force that they're able to generate. So, the idea is we're going to design the occlusion to try and boost that number up, to try and help a edentulous patient who's restored with conventional dentures. What we're trying to do is increase their ability to generate their maximum bite force. And then you could characterize that a little bit more, and we're trying to help them chew efficiently, chew effectively. So masticatory performance falls into that category. But just the overall ability to generate force goes way down with conventional dentures. So you want to now kind of contrast that with what would happen if we restored that patient with implants and, let's say, like full arch of zirconia. So now you've got a rigidly connected, no prosthetic movement, restoration of an edentulous arch. So natural teeth, 200 newtons, denture patient, 60 to 80 newtons. Best case scenario, most studies would say it's closer to probably 20 newtons for the average patient. But you start adding rigidly connected fixed prostheses for these patients, and it could go up to as high as like 1,200 newtons. So you restore a patient with fixed on implants, the force that they can generate goes way, way up. And so we have to kind of now design our occlusion for those cases to manage that force with someone who doesn't have the ability really to discriminate at a fine level of detail when the teeth are touching. Yeah, so the occlusal designs have to be totally different.
So for this removable patient, just to kind of dive into that a little bit more, you mentioned, the different ideas for the, fully edentulous upper and lower denture patient. Balanced occlusion, of course, is one design. Talk a little bit about, which design you choose most frequently. I know that there's proponents out there of balanced occlusion, and then there's also a lot of discussion about lingualized occlusion. So talk about that. What are kind of some of the pros and cons of those choices, and typically, like on a daily basis, what are you choosing for your patients with dentures?
Yeah, well, this is where the, kind of the concept meets reality. And I think all of us, well, I think in order still to pass the national boards, you have to have an understanding, at least on paper, of bilateral balanced occlusion for dentures. So the idea with that is, as the patient moves into any kind of a mandibular excursion, you have as many teeth touching in the posterior as possible. You want to do that in a way that it's all happening, the timing is all happening, so that it's a smooth handoff from one tooth to another. But you're trying to get as many posterior teeth to touch as possible into or away from MIP. And again, the idea there is we're trying to generate more biting force, increase the maximum biting force. We're also trying to, as let's say the mandible's moving to the left, so left lateral excursion, if we've got posterior contacts happening on the working side, on the left side, that's great because that's going to help the patient chew. But if it's only happening on the left side, then the right side is going to have a destabilization event, right? The dentures on the non-working side or the balancing side can lift off of the supporting structures. So the idea with a balanced occlusion is we'll have some tooth contacts happening over on the non-working side to help minimize the denture sort of coming up off of the supporting structures. Now, here's the challenge. And if you've ever, set your own denture teeth, you know that it's really tough to do that. It's really tough to get the timing worked out. You do everything that you can on the articulator, and then, the typical complaint from the dental student is that this doesn't look at all like what's going on when I see the patient. And so part of that is the accuracy of the articulation. Part of it is understanding that, conventional dentures move a lot clinically. Even best case scenario, you get the best fitting denture base in terms of its fit to the edentulous arch. Let's say it's perfect. You still have the compressibility of the mucosa that the denture is resting on, and that might be as much as like 2 millimeters of compression. So you're designing an occlusion knowing that it's not going to be nearly as accurate or as precise as what you're seeing on the bench. When it gets into the mouth, there's this reel and like effect that the dentures are moving all over the place. And so we're designing our occlusion to try and minimize that, to try and anytime teeth come into contact, we're trying to have those contacts work in our favor to help try and reseat the conventional removable prosthesis.
That kind of really...
Now, lingual...
I was going to say,
yeah,
like that kind of supports that during your denture delivery, you should be doing a lot of calibration and equilibration on that denture patient post-processing, right? I mean, if you're saying that we're working and we're setting these teeth on a hard, cast, right? And we do our try-in, wax try-in, and now we do a wax try-in and we go through the movements and we're checking everything there. And then we go back to the articulator and we say, okay, we give it our blessing and we have it processed by our denture lab if we're doing traditional techniques. And then we bring it back to the mouth. There should be quite a bit of time maybe spent just checking and making sure that you have the desired effect built in as far as balanced occlusion. Is that right?
Well... Yes. So
no, disagree with
Cradle,
me, Darin. Disagree. With me.
I mean, if the answer is no, then he's going to say just use Lingualized, I think.
Well, yeah. Let's talk about Lingualized in just a second. The first thing is at the insertion appointment, we have to critically evaluate kind of all of our work up till that point. So Jim Cradle, I think, famously said, the insertion appointment is essentially it's the appointment where you have to deal with all the sum of all the inaccuracies up to that point.
That's right. So
the denture processing is one place where inaccuracy can be introduced for sure, because the denture base, as it polymerizes, is going to have some distortion that occurs. There's going to be some residual stress. When it comes off the cast, it may have a twist or a distortion in it. The denture teeth can move during processing, and typically you can manage the processing error in the laboratory, right? So you should be able to, if you've got, the occlusal situation, the tooth arrangement, you've got your pre-processing situation. Post-processing, the technician typically can correct for that error. But what they can't do is correct for the error that we've introduced clinically. And part of that error comes in, like at the jaw relation record appointment, because we're working with record bases that are resting on compressible tissue, and the record bases typically don't fit as well as the processed denture base. So there's some inaccuracy that can occur there. So I agree with you. Yeah, we have to evaluate the occlusion, but in terms of time, sometimes, it's like you're surprised. Hey, this actually is great. Other times, yeah, I'm going to have to make some adjustment to the occlusion. And it's really hard to do that clinically because the dentures are moving all over the place. And so in my practice, the most efficient way for me to do that is once I've got the denture base adjusted, now we're at the insertion appointment. So I've got the denture base adjusted. Now I'll evaluate the occlusion. If it looks like I need to make a change or, clean it up, tidy it up a little bit, I'll go ahead and do a clinical remount. And then I can get it back on the articulator and I can dial it in, smooth it up, and correct for any inaccuracy that's happened at that appointment. So it may take me a long time, but it may not take as much time as you might think. So hopefully that makes sense.
No, makes
Yeah,
total sense.
But you have to
absolutely.
look at it. Yeah, you have to look at it.
Yeah, so I guess my
Lingualized
point.
occlusion.
Yeah, lingualized occlusion. Let's talk about that
Yeah.
because that
Yeah,
can
contrast that with
maybe change
lingualized.
something. Contrast that.
Yeah, lingualized occlusion is a form, can be a form of bilateral balanced occlusion. So a lingualized occlusion, if you imagine on the maxilla, you've got a cusp tip in the posterior that's going to land on basically a relatively flat receiving area on the denture teeth on the lower. So you can have on the maxillary teeth, you can actually have really nice anatomy, normal sort of occlusal anatomy there. On the mandibular teeth, though, the occlusal surface is going to be relatively flat. So you're not going to see like real steep cusp angles. In fact, you could set this up with a kind of a monoplane lower denture tooth in the posterior against an anatomic denture tooth on the upper and create your own kind of concept or your own lingualized version of the occlusion. But the idea is the maxillary palatal cusps are going to land in contact with the posterior relatively flat surfaces, and you can still generate bilateral. So working side, non-working side, you can still generate a bilateral balanced occlusion, but it's a much simpler adjustment to make because of the occlusal contact morphology that's happening posteriorly.
Is that kind of like in a lower occlusal guard, flat plane splint per se?
Yeah, it is more similar to how you would adjust a full coverage flat plane appliance. The difference is significant, though, in terms of how you develop the guidance. So as I'm developing a flat plane appliance for a dentate patient, I want to get my anterior guidance to try and separate the posterior teeth, trying to take advantage of the fact that there's an inhibitory effect that occurs for most patients when the anterior teeth touch. That's kind of one of the reasons we would use anterior guidance on patients that have teeth. And it's almost the complete opposite of what I'm trying to do with a denture occlusion, where I'm trying to get all the posterior teeth to touch, but I typically don't want the anterior teeth to contact because of the way that it'll destabilize the denture when the anterior teeth are touching. They're set typically so far off of the ridge. So I would think about those two occlusions as almost being the exact opposite, but the occlusal contact is going to look the same in MIP. Yeah.
Right. And it's much easier to adjust, like you say, for sure. Yeah, much less potential, and probably easier to teach, I would say as well. So much easier. It just maybe more. Now, the one thing I have heard about that is you do lose a little bit of the anatomy. And so the question is that I'd like to kind of hear you respond to is, does this change efficiency of chewing? Or is it really about that contact point? The fact you don't have as much of an anatomical lower tooth, does that change what we understand about how the patient can actually function? Or is it relatively equivalent to balanced occlusion?
Yeah, a lot of that chewing efficiency, masticatory performance work was done at UCLA. And when I was there, we were cleaning out one of the closets, and in the closet there were a couple of drawers that had these sieves, and one of the ways that you would measure in the laboratory or research project for a grad student would be you have the patient with their new dentures and you'll give them a chewing challenge. You'll give them peanuts, cashews, some kind of a soft nut, and you'll ask them to chew like 5 times and then spit. And so you can quantify the size then of the particles that are left over.
Sounds like a really fun project. Yeah.
Yeah. So understand that's kind of the level that this research that we're talking about right now was at. For sure, as we decrease the steepness of the cusps, as we go from like an anatomic tooth form on the denture teeth to a lingualized tooth form, and then take that one step farther and go to a monoplane, so a flat versus flat posterior relationship, the masticatory performance goes down. And what that means is the patient in controlled setting like that, like I just described, they're going to have to work a little bit harder to get their food chewed up, right? But they're already going to have to work harder because they're going to have to think about, at least initially, if this is their first denture, they're going to have to think about how they're controlling the denture as it's trying to move around and control where the bolus of food is at the same time. So it's quite challenging. But yeah, if you only look at the variable, one variable, you look at changing the morphology of the teeth, the steeper the cusps and the better the interdigitation is of the cusps, the upper versus the lower, the better the masticatory performance. But it can be then, you look at real world circumstances, and an anatomic versus anatomic occlusal setup posteriorly can actually be a little bit more challenging for the patient to adapt to. So if you think about like kind of the two ends of the extreme here, anatomic versus anatomic on one hand, and then monoplane, so flat versus flat on the other, lingualized kind of falls into the middle there from a standpoint of masticatory performance, because you've got anatomic form on the upper, and then you don't have, if you buy the denture teeth supplied, directly to you, you buy the denture teeth and they're designed for a lingualized setup. Typically today, the lower teeth aren't flat like monoplane. They've still got some occlusal morphology to them, but they're flatter than it would be like with a 33-degree denture tooth. So you lose some masticatory performance, but what you gain is easier design of the posterior part of the occlusion in the dynamic movements of the mandible.
John, I think that
so
you
it's
and
easier.
John, you and I both learned lingualized occlusion 15, 16 years ago, and it's what we've employed for the most part in our practices, and I have found it to be so much easier to manage as I've kind of went back and forth between, like say a 30 over a 20 or a 30 over a 10 even. The new, like Darin was saying, I feel like the new monoplane lower teeth that I'm using now on my denture patients, they actually look really, really good. I have had patients, I'll say this, Darin, in the past, not recently, I'm trying to think recently, have I had anybody complain of the look of the lowers? Because a patient it's funny, every patient just pulls it out as you're out of the room, maybe adjusting the upper or finishing your polishing, and they may look at it, or they're coming back and they're like, what's the difference here? Like, did you cheat on me or something like that? And I almost have to kind of like go backwards a little bit and explain some things that you're even talking about to the patient. And but it has gotten a little bit better, John and Darin. I think the anatomy is getting, even with these 0 degree or not quite 0 degree teeth for those lingualized patients, it's getting better, and I'm seeing less problems.
It's definitely getting better. They're prettier looking, and I think that in the end, I mean, the trade-off that we're talking about here, I mean, your maxillary anatomy still looks real nice, and which is what most people, of course, notice. So kind of bottom lining this a little bit, Darin, and I know that there are situations you might change your approach, but in general, is what we're hearing that you would say for the average situation, the average clinician, that looking toward lingualized occlusion is kind of what you would suggest we be working on or working with our lab on?
Yeah, I think the lingualized occlusion, if you're only going to know one, lingualized occlusion is the one to know. If you need to modify it, you can always grind it in so that it's essentially monoplane. You don't really lose on the maxilla. You don't really lose, there's no diminish in the aesthetic outcome there. So it's really what you're describing is the change in the morphology of the lower posteriors that is, really the aesthetic disadvantage there. But I try and head that off with the patients really early on, because I need for the patient to understand that we're going to make dentures that look like teeth, but they're not working like teeth. There's no root. There's no, like, the stuff that makes teeth work, you don't have anymore. So I want, from a social distance, which, like, okay, now we're all thinking 6 feet, but let's say, if you stand in front of a mirror at 2 to 3 feet away from that, that's where I want you to evaluate the overall aesthetic outcome, not taking it out of your mouth and looking at it.
Right.
if you like, I don't like, you may have a relationship with someone where you want to show them your denture, but generally the aesthetic outcome, you know, we're evaluating that at a much further distance. And so I try and set the patient up, you know, really, really early on in the process with that, so that it's not a surprise.
One question before, because I want to move. This has been awesome talking about removable. I want to start talking about where we transition this design as we talk about things that are more fixed in place. But one question we got from one of the listeners is, if you have to, you talked about doing clinical remounts. If you got to the end of that process, would you also ask for a lab remount and then a clinical remount, or would you just, are you typically in your situation just doing clinical remounts?
Well, my laboratory hopefully will have done a laboratory remount. The laboratory remount is designed to minimize or eliminate processing error. So laboratory remount is going to get you back to where you were with the wax trial denture. Clinical remount is where I'm able to compensate for errors that I've introduced during the clinical appointments. And so a clinical remount, the way the laboratory can help me is they can make remount casts ahead of time. They could actually go ahead and remount the upper remount cast, but I'm going to typically need to make a new bite record clinically. And so I will have to mount the lower remount cast myself. Yeah.
Gotcha. I think that helps to clarify just even the terminology for people that are kind of listening, because I think the clinical remount idea, it's something we're all taught. I think all taught in school, but I think it's good to kind of remember just all of the variability that comes from the tissues, and that even though you can go through all of this work to design your occlusion on the casts, that, you know, there's I find almost always going to need to do clinical remount. It's just kind of part of the process.
In fact, talking about go ahead. You can move.
Yeah, talking about this this exact discussion now, as we start moving into kind of the transition between fully removable and fully fixed. So let's talk about a prosthesis that is maybe kind of our quote unquote next step up, which would be something like an implant retained prosthesis, such as a locate or overdenture. Do you use a similar occlusal design in those situations, or do you start thinking more toward the designs you would use for fixed? And we'll get into what those are, but at what point do you start transitioning to a different type of occlusal design as you start thinking about restorations that are more stable?
Yeah. So in terms of more stable, right, as we add implants, and depending on the way that we're engaging those implants, or the way that we're benefiting from the implants to help with our removable prosthesis, what we're really trying to do is decrease the amount of prosthetic movement. And so the variable that I think about probably most in terms of influencing my occlusal design is going to be the degree of prosthetic movement that the case has. The more prosthetic movement that there is, the more I'm going to lean towards bilateral balance, a cross arch group function, or what we've been talking about so far. So you could use a lingualized approach for that, but I'm going to have contacts on the working side and the non-working side if I've got a lot of prosthetic movement, conventional dentures. As I start adding implants, I'm taking advantage of the retention of the implants, and in some cases, the stability and support of the implants, taking advantage of that so that as the patient goes into left working side excursion, left lateral excursion, I may not have the same kind of destabilization that's happening with the prosthesis on the non-working side, because the implants are there to retain the denture. They're able to prevent it from lifting up. Does that make sense? So, so my thought process is the more that I'm able to reduce the prosthetic movement, the more I'm going to lean towards a more simplified occlusion, because a balanced occlusion is really, it's hard to do. And hard means I'm going to have to spend more time on it. And I'd rather not have to do that. So if I've got implants, depending on the design of the implants to hold the overdenture in, I'll start thinking about going to a group function, working side only contacts. So I can now maybe not have to be so fussy about the non-working side contacts. Still, typically, I'm going to want to engage a bunch of teeth. I don't routinely with this scenario go to anterior guidance or like a canine guidance type of a situation with implant retained overdentures. I would go with a group function. I'm trying to get as many teeth to contact as possible as the mandibles going in that excursion into or away from MIP. But because I've got the benefit of the implants, I don't have to go through the next level of hassle with managing the non-working side contacts.
I think it's a good answer, because here's the thing: as stabilization improves, right, we can try to increase the mascatory, if I'm saying that word right, that's a tough one to say. If I want to basically increase chewing efficiency, right? And so if I can increase my chewing efficiency, you could say this to the patient. I think this is a great way that I explain it to patients, and the way my assistants explain it when they're choosing the disadvantages and advantages of prosthetics, because this is the conversation we have when it comes down to, hey, here's what the best is, here's what the medium of the road is, and here's what the lowest is. And the prognosis is that the more stable your final prosthetic is, the better you're going to be able to chew. And so the more implants sometimes, if that's the case, that creates more stability in the prosthetics, the better you're going to be able to chew. And so that helps the patient to kind of understand some basic things about, oh, okay, that means I'm going to need more implants to have this one, and that's going to make it, where I can chew better. Is that kind of how you're explaining it to your patients, Darin?
Yes, it is really similar. The concept that I want the patient to have is we're thinking about the options. One option would be conventional removable. Another option would be potentially fixed on top of implants. A third option would be an overdenture that's going to take advantage of implants and kind of fall somewhere in between. Now, reality is, and we've talked about this, I think, on one of the other shows that we did, you can't always do fixed in the edentulous maxilla. And so I'm really careful early on in my conversations with patients. Even, their first question is, I'm edentulous and I want to get something fixed. I need to help them understand that there are times that we can't do fixed in the maxilla. So if you want to, know more about that, let's figure that out. And so I'll have those kind of conversations. But I also, I don't want to so negatively downplay the functional outcomes with conventional dentures for a patient that they believe that they will never be successful. Because what we know is a lot of patients are successful with conventional dentures. People can adapt. And so where we see the variability in this outcome with conventional dentures, a lot of that has to do not with how well we've designed the occlusion, but it's got to do with the patient's capacity to adapt to a really, really significant change. And some patients can do that really well. Especially young patients, right? An ectodermal dysplasia patient who, never had any teeth but got dentures inserted when they were young and had, a series of dentures made as they've moved, from childhood to teenage years and whatever. Those guys are amazingly adept at using conventional dentures. So people can adapt. But if you can't, and there are some patients who can't, good to know that we have some additional options. And so, like, if I'm transitioning a patient from a terminal dentition to something else, not a bad idea to allow them to have the opportunity to work through immediate conventional dentures. So when you and I say, conventional dentures are going to move a lot, and with time, most people can learn to deal with that. They get to actually feel that. They get to wear the dentures, and so they know what we're talking about. And if they know how bad that is, when you go to anything with an implant, like even one implant, it's going to be a lot better than no implants. And so that that being able to discriminate the improvement there, I think, is really helpful.
So let me ask a question that I think we should be asking, but often isn't discussed. How does the configuration of the implants in say a locator overdenture change the way you think about the occlusal design? Because we all have our thoughts or discussions on where should the implants be placed. And, in ideal situations, say with let's pick the most common situation I think we are presented with, which would be, say, the 2 implant lower locator overdenture. Where those implants are placed changes things about fulcrums. And that's something that can change the way that not only things function, but also the wear on the resilient parts of the attachments. So do you change the way that you think about the occlusion depending upon how well the implants are paralleled, the heights of the implants, or do you really think about that kind of the same way across the board?
Yeah, the implant number, the implant distribution, and the nature of the attachment all play into the increase or decrease or the outcome of the prosthetic movement. The way I would think about it with respect to designing the occlusion is I'm going to look at the upper and the lower arch, and I need to design my occlusion around the weakest arch, or the arch that's going to have the most prosthetic movement. So in the scenario that you're describing, 2 implants, and then we're going to use locators on the mandible. If that's opposing a conventional denture on the upper, I'll typically think of the case occlusally as if it is still a conventional versus conventional, because the weak link there is the maxillary prosthesis.
That makes sense. Yeah, that's a good way to think about it. Look at what has the biggest chance of being a problem and design it appropriately. So now let's talk about, because I think this will feed back into that discussion. Let's talk about the fixed prosthesis, the full arch implant prosthetic, and let's maybe talk about fixed versus fixed, because I think it's the easiest way to have a contrast. And I'm guessing that you're going to say that you change a lot about the way you think about the occlusion, but kind of talk through that with us, and how do you think differently about the occlusion, and at what point do we make the transition? And we can maybe get into that later, but I think if we did look at the fixed versus fixed, what are some of the things you would tell us to be looking for?
Yeah, so fixed versus fixed. Now you're going to have some materials differences that occur here. We'll get to that in just a second, but just generally speaking, right? You've got fixed versus fixed. If we go back to the bite force ideas, maximum bite force ideas that we talked about a minute ago, natural teeth, 200 newtons, Bruxer, 800, 900 newtons, implant versus implant, 1200 newtons. It's the potential. It may not be for the patient that you're working with on an individual basis, but it's got the potential, generally speaking, to be the highest amount of occlusal force that we could experience in practice. So we got to design those cases to manage the potential for occlusal force. And then it's not just the amount of force, because that's significantly increased, but the patient also isn't able to discriminate when their teeth are touching. So they become clumsy almost. And so they can, close down into that maximum bite. And maybe the mandible isn't perfectly lined up with where the maxillary occlusal teeth, the occlusal surfaces are. And so the mandible's slightly off. The patient goes and slams the lower jaw against the upper jaw and chips a tooth, right? That's kind of typically how that looks. So what we're trying to do with these guys is now manage too much occlusal force. We've got too much of a good thing. We have to deal with that, and the way that you deal with that is basically the same kind of concept that you would use to try and manage too much maximum bite force with your worn dentition patients. Someone who's got the ability to kind of wear their teeth in a vertical movement and in a horizontal movement. So they're coming in pathways and onto the edges and potentially into crossover. We're going to have to create a really permissive occlusal design So MIP doesn't really change. MIP, you're trying to get as many teeth in contact, so you're sharing the force over as many tooth contacts as possible to distribute that load over as much surface area as possible. But then when it comes to thinking about the dynamic occlusion, so left, right, lateral excursion, we're still trying to share that load over as many teeth as possible. And so a lot of times I'll be thinking about a group function in order to do that, but group function unilateral. So on a fixed case, it's really, really tough to make bilateral group function or a balanced occlusion. So group function is technically easier to achieve on a fixed case. And typically that's going to allow you to distribute the forces that are occurring in a dynamic movement over as many tooth contacts, which translates into more surface area. So same amount of force over a larger surface area or more surfaces is going to decrease the overall amount of force that's applied to any one part of that situation.
Now talk about,
but that's only
why you would go ahead. No, continue. I'll let you.
Well, yeah, I just to kind of take that the next step. Then, if you're going to design your group function, the next question is how many teeth are going to touch, or how far back do you bring your group function?
Right. That's what I was going to.
So if you start, okay. So I mean, that's a really good question, and that's a mechanical question, or at least it's a mechanical answer. And if you think about that 200 newtons that the patient's able to generate at the, let's say measured at the first molar. If you measure maximum bite force in the incisors, it's way, way, way less than that. In some articles, it's going to be, 25 newtons compared to 200 newtons in the posterior. Some articles will show there's like a 3-to-1 relationship. But whatever, I think every article that I've ever looked at agrees with the premise that there's less force generated on the anterior teeth than there is in the posterior teeth, and that's a mechanical outcome, and it's a mechanical outcome that's based on the length of the fulcrum arm, or where those tooth contacts are in relationship to the condyle, or relationship to the joint. The farther away the tooth contact is from the fulcrum or from the joint, the less force you're able to generate. So anterior guidance makes sense from a mechanical standpoint because the patient isn't going to be able to generate as much force on the anterior teeth as they are in the posterior teeth in this kind of a setting, right? But the risk is if we go with canine guidance on a fixed over fixed case, we are still concentrating any remaining force on one contact area. Mm-hmm. So group function allows us to create less force on any one contact by picking up more surfaces that are in contact when the mandible goes into excursion. Mm-hmm. So the risk is you say, I want to make a group function, and you bring your group function all the way back to the second molars. Well, the second molars, you're able to generate like as much force as you could ever generate. And so, yeah, you're sharing that load over a bunch of teeth, but the second molars are going to take a really significant hit there.
Right.
So typically,
and you may have a cantilever there too sometimes as well, right? So that's you're thinking about that
for sure.
Too.
Yeah. Yep. So yeah, so you've got a cantilever. That's kind of a biomechanical thing that's going to be a risk factor now for the implants or for their overall kind of materials. But yeah, you'll have a cantilever in the maxilla with almost 100% of the time. So you got to think about that from a materials failure standpoint.
Yeah, that kind of leads into that next question, though, right? Do you, based on
how far back do you go?
How far back do you go?
Yeah. So how? Well, Ricardo Matrani, Doug.
He's listening, by the way, so be careful what you say.
Is he? Oh,
yeah, he said you're on fire. He said you're on fire right now.
That's awesome. I spent we talked about this or not, but Ricardo's practice is in Mexico City, and I've spent a lot of time at that practice in Mexico City, and so we've had the chance to kind of mind meld over these concepts as we've been working on things like our seminar, the edentulous workshops that we do, and Doug Benting's been a big part of this. So if you were to ask Doug, how far back is he going to go with his group function? He's probably going to go back only as far as he has to. So that's going to be the canine, first bi, second bi, and maybe the first molar. If you've taken one of the bis out, right, you essentially shorten the arch. It may be canine, the single bi, and then the first molar. But so you're picking up like 3 contacts instead of just one. Mm-hmm. But knowing that as you start to progress more posteriorly, the force on those contacts is going to significantly go up, and so does your risk. If you were to ask Ricardo's had a lot of success using anterior guidance, canine guidance on these cases. But the reason that he's been able to be successful with that isn't the fact that he's using canine guidance. It's the fact that he's using a really shallow disclusive angle.
Right.
Okay.
So there's a canine guidance happening there, but it's not a steep canine guidance and it's not a long canine guidance. So the disclusive angle is really shallow. The patient, as the mandible's moving, traveling down the palatal surface of the maxillary canine, that is going to be a really shallow angle, and it's going to be short. There isn't a bunch of time that's occurring where you're creating a lateral force on that part of the prosthesis before you get to canine edge to edge. Mm-hmm. So shallow disclusion is probably actually more important than if you're going with canine versus canine bis and maybe the first molar. It's the shallowness of the disclusion that I think is really critical.
That is so good. So
Man,
good.
When you're talking about these contacts going further back, when you're talking about trying to minimize that, are you talking about both MIP contact and excursives that you're looking at it the same way? Or is it more for your excursive contacts that you're concerned about those being further back?
Yeah, it's typically the excursive contacts. When I think about the hard part of designing an occlusion, it's the excursive contacts. It's the dynamic movements. That's where our bruxers break things. That's where these patients can break things. But these patients, the fixed over fixed patient, they may actually grind their teeth, right? There's all that stuff may still be happening. But even absent any kind of bruxism, daytime diurnal or nocturnal bruxism, awake or sleep bruxism, however you want to categorize it, absent any kind of a bruxing movement, they can still break things because they've lost the ability to discriminate where their teeth are relative to one another. They don't have the somatosensory information from the PDL telling the brain, telling the cortex that, yep, your teeth are contacting, and so you need to decrease the amount of force because we're there. Or the teeth are contacting, go ahead and increase the amount of force, right? None of that is happening. The teeth just slam together, and they will squeeze until like it feels like, the contact there is solid. Right. So the dynamic movement, those dynamic contacts are really critical to help get the mandible back into an MIP. And once we're in MIP, now we have a lot of tooth contacts, and that's going to help distribute the load in the maximum biting force in MIP.
John and I have had this conversation about full over full for the past forever, and it's I mean, it seems like that's what we talk about this all the time, and it's a continual conversation, and that's how we produce this show, because we're all the time kind of scheming about, okay, here's the next case I've got, how are we treatment planning, how are we working through this. And let me tell you what the number one thing that comes up in the decision tree, well, I shouldn't say number one of the things that always comes up in the decision tree with John and I is, what about dissimilar materials? When we're doing full over full fixed, there's this conversation that John and I have is like, okay, if we want to maximize aesthetics, then we're using zirconia in the upper, but what are we opposing, right, that with? Or is there, what do you think about that?
Do we choose a material to be a scapegoat, to take, to be the failure point because it's a weaker material? Because you keep saying these words, like they'll just keep clamping down until they feel it's solid, and that's where they break things, and it makes us nervous because as we talk about the zirconia versus zirconia clink, of the teeth coming together, it makes you a little nervous when you know that we lose that proprioceptive ability, and the perception of force is different. Discrimination of food is different. So are you, how confident are you if you feel you can create, this type of occlusion with having two very strong materials opposing each other, or do you like to have something that kind of can give if something's going to wear out?
Mm-hmm.
Yeah. I wish that there was one answer for this.
There's not.
Yeah.
Yeah,
It's
there's
hard.
not.
So hard.
So, I mean, it's the same thing we've been talking about with occlusion, right? Rather than try and give you a recipe that's going to work 100% of the time, there just isn't one. So understanding the concepts will allow clinicians to kind of look at the case that they have in front of them and say, well, okay, here's what I'm going to try. And then if it doesn't work, at least you knew what you tried initially, and then you can go to plan B. And so as I'm thinking about fixed over fixed, yeah, you can get some idea about how the patient's going to destroy, because for sure they're going to destroy it. It's a matter of how long it's going to take them to destroy it. So
right.
When you're in the provisional stage, you can get a sense of how much wear is occurring here. And you can evaluate the patterns of wear to see what they're doing. And then you may decide that you want to take that into account in your definitive prosthetic design. And so as I'm thinking about fixed over fixed, building in a prototype. So like, let's say it's going to be zirconia over zirconia, like you guys were just describing. I'd want to go with a milled prototype, a milled provisional, insert that for the patient and let them try and destroy that. I want to see how that's going to fail. And that'll give me some insight as to do I need to change something with my occlusal design? Did I miss something? Or, do I need to pick up additional teeth in my group function or whatever? So that's one way to try and manage the risk there. The other way is to just say, well, okay, I'm gonna create a weak link, a pressure release valve or whatever, and so you'll go with your layered ceramics or your zirconia or whatever is going to be on the maxilla to get you the maximum aesthetic, bang for your buck. And then knowing that the lower typically doesn't have the same aesthetic demands as the upper does, you can use something that's designed to fail on the lower, and by doing that preserve the upper. So that's where like a fixed hybrid, a metal and acrylic hybrid, can be really nice. Not my favorite material for sure, but one of the advantages that a fixed hybrid has, a metal and acrylic fixed hybrid has, is that it's really easy to repair. So you can take it out, strip all the acrylic off, reprocess it and put new denture teeth on, no problem. You can do, a little bit of repair here and there if you need to, no problem. It's really easy to bond to it. And contrasted with trying to bond to zirconia, it's a little bit more challenging. So if I'm going to make a sacrificial arch, it's going to be on the lower. And one of the challenges that you'll face if you do that, though, is making a believable relationship aesthetically between the maxillary anterior teeth that are typically going to be, have some kind of layering ceramic. Even if it's a minimal cutback, there's going to be some kind of a believable outcome there. And then blending that in with the denture teeth in the lower anterior so that it looks like those teeth came from the same DNA, right? And that's an aesthetic challenge, but it's one approach to dealing with the fact that the patient's likely to destroy things. And the benefit you get there is not just that you have one arch that is less aesthetically, demanding, and you're going to have your problems there. It's also the way that the arch will break down. If you've got fixed versus fixed and zirconia versus zirconia, when it goes, you're going to see a chip or an overall like fracture, like it breaks in half, or you lose a tooth. You get real big ceramic failures. The denture teeth, you might have a denture tooth that debonds from the denture base. You might have a chip, depending on the material in your denture teeth. You might be able to see it chip. But most commonly, the denture teeth just kind of wear, they just dissolve. They've got a, so it's almost like rather than have this explosion, you have this really slow burning process. And so that allows you to be able to evaluate what's going on with the lower arch. And then you can better plan for it. So it's not like a 9 o'clock on Friday night call, hey, number 8 just broke. I need to get this solved right now because I have an event tomorrow.
Right.
If it's a slow burn on the lower, they're going to get uglier, and it may change your occlusion a little bit. But it's way more predictable, I think, in practice.
I think, a lot of dentists are building in some protection by doing these things and really trying to create a weak link, which is what, Greg Kinzer teaches, is that build these things to fail. Just find out where that failure point can be easiest repaired, and it might be choosing dissimilar materials, which I'm in agreement with you. I think that a lot of dentists immediately, John, they immediately jump and they say, well, let's just put our patient in an occlusal guard. And I think that we have to be very, very careful about that, Darin, and I want you to speak to that. I'm not saying it's wrong. I'm not saying it's right, but I think that that's just a slam. Every full arch patient gets an occlusal guard, and that seems to be a blanket statement we hear a lot.
Yeah. Well, so we talked about changing the materials, right, to manage the wear that's occurring. We could change our prosthetic design to help manage the forces. So you go, rather than fixed over fixed, you go fixed over removable, and on the removable arch, you've got some resiliency built into the system, some prosthetic movement designed in to help allow that excess energy to kind of spill onto the soft tissue rather than go to your materials. But at the end of the day, the patient's going to go home with something. And so does every patient get a night guard? Well, here's the problem, is that anytime you give a patient a night guard, you're assuming that they're, number one, going to wear it, and number two, that they're creating the challenge to your materials at the same time that they're wearing the guard. So like a night guard, right? If they're grinding their teeth at night and their teeth never come together during the day, if they wear that occlusal appliance at night, from an occlusal wear standpoint, an attrition standpoint, or a material fracture standpoint, could be really helpful. But if they are destroying their teeth during the day and they're not wearing their appliance during the day, it's not doing a whole lot of value, giving you a whole bunch of value at that standpoint. Now, having said that, these patients do get night guards. It's kind of I'll do everything I can with the occlusal design to distribute where the force is going, the prosthetic design to distribute where the force is going. But at the end of the day, they do, on a fixed versus fixed case, typically get night guards.
So if going back to kind of building things in, when we, before we really understood as much about Airway and what was going on with wear, we weren't thinking about the way that we were designing occlusions to kind of allow for some of the movement that maybe people were going through. We've talked a lot about that in workshops with teeth, about restoring patients in ways that they can go through movements where if they're going to protrude the jaw forward, for instance, that we give them, like a long centric type of approach to their restoration. Do you think about things with implant restorations, or whether it be conventional dentures, whether it be fixed over fixed implants, to how are you accounting for that, especially if you see the patient before they become a dentulous and you maybe note some of those types of patterns, or maybe you identify through some testing and through some through the physician maybe that this patient has sleep apnea. Does it change the way you think about your occlusal design in the edentulous patient?
That's a great question. Does it change my thinking about the occlusal design? Maybe, but it's not really the occlusal design on the prosthetic teeth. It's more the occlusal design. I mean, I guess it may be if like the patient is a skeletal class 2 and they've on their natural teeth, they kind of had the tendency to come forward. yeah, that would be a really challenging scenario, but I could see where a long centric would be helpful for something like that. But the way that I think about, like, let's go to a fixed versus fixed. The way that I would think about that now from an Airway standpoint is they're going to get treated, in my mind, exactly the same way a patient who is dentate would be treated. And they'll go through the Seattle protocol that if they've got an airway issue that we've identified, then the next step is to figure out how much help do they need from an airway standpoint. And so you can go through the Seattle protocol, and really what you're trying to do is determine, okay, I'm going to make a night guard, as we said a second ago. I'm going to make a night guard for this patient, but I don't want my night guard to negatively impact the patient's ability to breathe. So I'm going to develop a night guard that's designed to improve, if anything, their ability to breathe. And so Seattle protocol has been really helpful for that.
Yeah.
And where it gets challenging,
I think that's how. Oh, go ahead.
Oh, no, go for it.
I was just going to say that's what I kind of thought you would say, is that you would say that you would treat it similar to you would with teeth, that it's kind of going down the same pathway. And because we can still make appliances for these patients. We can think about especially for the fixed over fixed patients, we can think about them. And where I do wonder what you'll say, though, is for your fully edentulous patients that have removable prosthetics, how do you deal with that in the airway situation? That seems like a challenge. Do they need to maintain their vertical at night? Do they need to be wearing appliances at night? This is an area I don't know a lot about. What are you thinking about in those types of cases?
Yeah, well, when you get Rouse on this show, that's a good question to ask Rouse.
Is that a Rouse question?
He sees a lot of edentulous patients, and obviously he sees a lot of airway patients too. So he would be the person that I would ask that question to. But I think what it's going to come down to is again individualizing the amount of help that the patient needs. So a conventional denture wearing patient who's using a CPAP, they may actually, depending on the configuration of the mask, they may need the denture there to help support that whole situation, to keep the airway patent, to keep the mask where it's got a good seal over the face or however it's being attached. And so it may be that the recommendation is, wear your dentures at night so that the intervention that we're doing from an airway standpoint is more helpful. But we know that wearing dentures at night comes with its own set of problems, right? So now we're going to trade that off to improve the airway, because that's a potentially life-threatening situation. So we want to maximize the airway, and then we're going to have to deal with the complications that come along with that approach. So maybe during the day, there's going to be a time where you have to take the dentures out for a while, let the soft tissues rest, make sure that the dentures are clean and that sort of thing.
There's all kinds of little nuances and things that you're going to run into, but I think what we've established today is a really good overall general sense of what knowledge we need to kind of start thinking about, right? Because there's a breadth of knowledge that we just covered, and it's so hard to jam-pack that in to just 1 hour of a discussion. And one of the things that I think that is good is that Darin has really dove in and to Spear, and he's part of this from the very beginning in your learning, really. As you move from facially generated treatment planning, the workshops there, into occlusion, Darin, you've actually started teaching occlusion as a part of the Spear continuum of workshops. And I want you to talk a little bit about what you're teaching right now, because I think that if you're listening to this right now and you say, you know what, whoa, I'm seeing some of those things in my practice. How can I know more? And yes, we want to tell you that this is where we've learned most of our knowledge is from Spear Education. And Darin, I want you to kind of talk a little bit about that.
Yeah, thanks for bringing that up. I took over, along with Gary DeWood, I took over the occlusion workshop a couple of years ago now. Kind of lost track of when that was. But if you look at our continuum of education on campus, facially generated treatment planning is kind of the first workshop. And so in that workshop, you're coming up with approaches for how you would determine where you want the teeth to be. where you want the soft tissue to be. You're coming up with the overall vision for the aesthetic outcome of the case, right? And in that workshop, we do things like photography, and then you use the photography to help you kind of figure out your overall treatment plan. In the occlusion workshop, we start thinking about, okay, now I know where I want the teeth to be. How am I going to design the occlusion to make that work? And a lot of people, I think, who come to an occlusion workshop or an occlusion lecture or just this topic of occlusion kind of come to it with merging the idea of you've got occlusion on one hand and you've got dysfunction, pain, TMD, all that kind of stuff on the other hand. And these two ideas get put together. But the truth, and so I'm not saying that doesn't exist, that relationship doesn't exist, but the truth is that most of your patients in your practice don't have TMD problems. Most of your patients don't have like myofascial problems. They're normal. And we still have to think about occlusion and occlusal design with respect to how we're going to build our cases. Because it's a perfect world, right? Your patient has no joint problems. They have no occlusal dysfunction, but they're still going to get some treatment. And we have to now, we've changed their existing occlusion. We have to now know what we need to do to build them a new occlusion. So that's kind of what we start with in that workshop. And in order to do that, you're going to have to get the case mounted onto an articulator. And so we go through how you use articulators, how you use face bows, how to make predictable, repeatable bite records for the patients that you'll most often see in your practice. And I think in a general practice, you're way more likely to see an average healthy person who's going to need a little bit of dentistry than you are likely to see the patients we've been talking about, over the last hour. These patients, they need all the same stuff. The edentulous patients, you're going to have to articulate those cases, right, in order to manage the occlusion. And so the occlusion workshop kind of sets you up to have a foundation to be successful with occlusal design for worn dentition cases, for airway cases, and for edentulous cases.
So the next stop, when you go on from there, you're actually teaching what we're talking about right now. You cover this in the edentulous workshops as well, right? You talk about some of the same occlusal design.
Yeah. So where, dentists would see me would be after the occlusion workshop, you'd see me again in the worn dentition workshop. So how do you come up with your occlusal design for dentate patients or partially edentulous patients based on kind of the tooth wear patterns that you've identified? And then you'll see me again in the edentulous arch workshop, restoring the edentulous arch. That's Doug Benting and I put that together a number of years ago. And one of the real benefits to that workshop is it's a hands-on workshop. A lot of concepts, a lot of ground we have to cover there. It's really broad. And so the hands-on exercises in that workshop are designed to be universal. So even though we're using one implant system and one attachment system for an exercise, the concepts are exactly the same for almost every other implant system that you would see and almost every other attachment system that you would see. So that's kind of the approach that we take in that workshop. And then Ricardo Matrani and I have for a number of years been doing terminal dentition and treating the fully edentulous patient seminar on campus. And we're actually, we've transitioned our seminars to online platforms now. And so I think the first week in May, Ricardo and I are going to be presenting that terminal dentition and treating the fully edentulous patient. We're going to present that in a virtual format, an online format, during that first week in May. And I'm not sure the exact days. I think it's the 7th of May, but it's a 2-day event.
Gotcha. Well, that tells people, I think, where they can go if they, because I think these topics are definitely overwhelming. We got some good, nuggets today, some places to start and kind of ways to think about this topic, but certainly a lot of expansion on those things, to say the least, when you go out to these seminars, let alone the workshops. It's very cool that you guys are expanding so quickly out to the online world with the seminars too. I'm excited to kind of see how, I think it's going to expand your reach in a major way. So, I think that I always, whenever we talk, it always kind of gets me thinking about, going back to my practice and kind of changing a few things, thinking about things differently. You've helped us to answer a lot of the questions that I think we get from a lot of our listeners about this topic. Definitely go check Darin out and head over to Spear Education, see what he's up to, and highly recommend that if you get a chance to sit in on some of his workshops and seminars, it's definitely worth your time. Darin, we thank you very much.
Thank you so much
being
for
with
being on
us
the show
today, and it's awesome to have you back. If you want to learn more about what's coming up with the Dental Guys, you can, of course, head over to thedentalguys.net. Also, you can check us out on the socials. And, of course, Spear Education as well is very active there, presenting a lot of good content right now, too, through the time where we're all hanging out, hopefully not stress eating and actually learning something. That's the goal anyway. So I think they've been putting out some great content. We're trying to also do the same, continue to bring you some great content. And we've got more coming up in the coming weeks. Also, too, if you haven't already left us a five-star review on Apple Podcasts, shame on you. You should be doing that right now if you haven't already. So we really appreciate when you do that. It's what allows for us to get our message out to people who are searching for good content. And if you like what we're doing, then let us know. That really helps us a ton. If you have any questions for Darin or for us about the show, please leave them in the comments below the live video. And this will be re-released as a full episode in the coming days. Thanks again to Darin for being with us today, and always fun to hang out with him. And so for Darin, for Wes, I'm John, and this has been another great episode of The Dental Guys.